Hello and welcome to the special edition of Cystic Fibrosis Review. I'm Peter Mogayzel and I'm here with Dr. Ken Olivier, who's a staff clinician in the Laboratory of Clinical Infectious Disease at the National Institute of Allergy and Infectious Disease at the NIH in Bethesda, the United States. We're recording this interview at the 36th Annual European Cystic Fibrosis Society meeting in Lisbon, Portugal. Ken, welcome and thank you for joining me.
Thank you.
I wanted to talk to you about mycobacterium. It seems like there's a lot of interest in mycobacterium in cystic fibrosis. Why is that?
I think probably two reasons, Peter. One is probably an increase in prevalence of finding these organisms. The second is the difficulty in treating them and the significant morbidity and unfortunately sometimes mortality associated with severe infections caused by these organisms.
Is there more nontuberculous mycobacterium now than there had been previously? Can you tell me a little bit about the epidemiology and prevalence of nontuberculous mycobacterium in people with cystic fibrosis?
Yeah, it's been a difficult thing to assess. Unlike tuberculosis, which is a reportable disease in the United States, there is no reporting requirement for the nontuberculous mycobacteria. So we can't go to a website like we can for TB and look up annual prevalence of it over time. So we've had to devise different ways of getting at what the prevalence is. In the mid-1990s, the USCF Foundation funded a large multi-site study where we went in and prospectively looked for mycobacteria in about 10% of the USCF population over the age of 10. And in that study, where we obtained 3 sputum samples over the course of a year to look for mycobacterium, the prevalence was around 13%. It would have been nice at that time to use the Foundation Patient Registry to look at this, but at that time, the way the questions were structured, the prevalence estimate when we were finding 13% in CF patients was around 0.4%. So at least at that time, it was not a valid way to look at this. There have been a number of single-site surveys that have reported a prevalence anywhere from 6% to well over 20% among CF patients. And one of the things that's apparent is that the prevalence of these organisms tends to increase with age. In 2010, the USCF Foundation increased the number of questions on the registry to allow us to look to see how often patients were cultured, to see what species were recovered, and to find out which of those patients were on treatment. This has greatly increased the utility of the registry in being able to track these infections. And in recent looks at this from the years of 2010 and 2011, the prevalence looks very similar to what we found back in the mid-1990s by prospectively looking for these organisms. The main difference involves having to rely on retrospective analysis of cultures that were obtained. So we still have no way of knowing why a culture was obtained and what's different about the patients where mycobacteria was not looked for versus those where it was. And so with that sort of cautionary word, it looks like the overall prevalence of mycobacteria is remaining constant, around 10 to 13%. The big difference, however, has to do with the mixture of organisms that's been recovered. In the mid-1990s, about 80% of the organisms were from the Mycobacterium avium complex, which in general is a bit easier to treat than the 20% at that time recovered as Mycobacterium abscessus. When we've looked more recently at either large single-site surveys, such as the one done at the University of North Carolina, or in looking at the registry data from 2010 and 2011, the prevalence of Mycobacterium abscessus has gone from around 20% of the recovered isolates up to around 50% or just over 50%. And that's presented with significant treatment difficulties given the difference in response between those two organisms. If you couple that with data that has been obtained outside of CF, looking at the overall prevalence of mycobacteria in the U.S., done either through isolate bank searching with coupling that through electronic medical records to establish a case definition, or in recent studies that we've done with the U.S. Medicare database, it's clear from those studies that over the past 10 to 20 years, the prevalence of mycobacteria overall is increasing in the background population of the U.S. for reasons that aren't entirely clear.
One of the challenges we have is deciding when to treat a patient with mycobacterium. What are your thoughts about when someone really needs to be treated?
Well, in a way, this is a bit easier to answer outside of cystic fibrosis, particularly in patients that have no apparent underlying cause or predisposing factor to this. We rely on a combination of symptoms such as chronic cough, appropriate radiographic changes such as peripheral nodules associated with bronchiectasis or cavities apparent on the radiographic studies, and couple that with appropriate microbiologic assessment of finding the same species of mycobacteria on at least 2 separate respiratory sputum specimens. In the setting of cystic fibrosis, if you use those criteria strictly, that might define many patients who had infections from Pseudomonas or some of the other usual pathogens that are seen in CF. And so in cystic fibrosis, the general recommendation is to aggressively look for and treat other common etiologies of those symptoms and radiographic findings such as Pseudomonas or staph, and then to assess the clinical status of the patient. And so in those patients that either fail to respond to the usual CF pathogens or have no other pathogens recovered other than mycobacteria to explain those findings, or in patients who are having increasing frequency of exacerbations despite appropriate treatment with suppressive antibiotics, those are generally criteria that are used to establish mycobacteria as a cause, especially coupling that with repeated recovery of the mycobacteria over time.
I know that you're working on guidelines that are a collaboration between the Cystic Fibrosis Foundation and the European Cystic Fibrosis Society. Can you tell us a little bit about how those guidelines are being developed?
We're actually very excited about this. I think this is one of the first times, if not the first time, where we've established joint guidelines between the European CF Society and the US CF Foundation. And I have to say, over the past year or so that we've been working with this guidelines committee, there's been a tremendous amount of cooperation and now consensus across the Atlantic on both sides. There are a number of representatives from out Europe and throughout the U.S. as well who have participated in these guidelines. And while they're still in progress, we have all come to a consensus on the essential questions that are important to ask in this disease and general recommendations to answer those or address those questions. We're at the stage now of putting together the text of the guidelines, which will then be sent out for peer review. So while we're all in consensus, there may still be changes coming about through the review process or in the context of wordsmithing to get the final document prepared.
And will the guidelines cover both identification and treatment of mycobacterium?
They will. So the guidelines will start with an introductory section on the epidemiology of disease, similar to what I just described. And then there are sections that relate to screening for mycobacteria, to diagnosing the disease, and finally to treatment, which will include both medical treatment and surgical treatment.
So Ken, how should clinicians approach the treatment of nontuberculous mycobacterium?
Well, Peter, for these guidelines, we've divided them sort of in half between treatment of Mycobacterium abscessus, which again I think is an organism increasing in prevalence and certainly increasing in importance in CF, and treatment of Mycobacterium avium complex. And as I previously mentioned, the treatment response tends to be quite different from those two organisms. The Guidelines Committee fully acknowledges that the treatment recommendations that we are making are based on very little science. There's just not a lot of literature or clinical trials to support this. But there's been a growing request from the CF community to have a set of treatment guidelines laid down that could then be tested in a clinical trial setting. And so I think the approach that the USCF Foundation has taken in both supporting these guidelines and in follow-up studies is to support the use of the patient registry as a way of following outcomes for these organisms and to almost immediately put the guidelines in place in a setting within the TDN that can then be extrapolated to other centers to look at outcome measures. So with that introduction, the treatment guidelines for Mycobacterium abscessus call for 2 phases of treatment, the initial intense phase and a continuation phase, almost equivalent to the way cancer chemotherapy may be structured with an induction and then a completion phase following that. The intense phase of treatment is recommended to last anywhere from 3 to 12 weeks based on patient response, and if patients aren't responding appropriately, it may need to be altered or extended for even longer periods of time. But that initial treatment will call for the use of an oral macrolide, and azithromycin is recommended over clarithromycin. 3 to 12 weeks of intravenous amikacin, and the use of 1 or more of the following intravenous drugs, either tigecycline, cefoxitin, or imipenem. And again, that would be continued for at least 3 weeks, up to 12 weeks, depending on patient response, and then followed by a continuation phase. And the continuation phase, again, would call for an oral macrolide, but change of intravenous amikacin to inhaled amikacin, and coupling that with 2 to 3 of the following oral drugs, either clofazimine, linezolid, or moxifloxacin along with that. And then that continuation phase would be continued until the patient's culture convert and then remain culture negative over a period of 12 months. For Mycobacterium avium complex, the recommendations are to basically follow what's been recommended in the ATS-IDSA guidelines, which again calls for an oral macrolide, ethambutol, and a rifamycin, either rifampin or rifabutin. And the recommendations are for daily therapy as opposed to what's in the general guidelines, which gives the option for 3 times a week treatment. And the reason for this was because of the more common occurrence of significant structural lung disease and CF that would require a more intensive therapy. In those patients that are either smear positive or have evidence of cavitary involvement on chest CT or radiographic studies and who have systemic symptoms, there's a recommendation for the use of intravenous amikacin during the initial 2 months of that treatment regimen.
I wanted to ask you about one last thing, which is infection control. Is there a greater concern about transmissibility of mycobacterium between individuals with cystic fibrosis?
If you had asked me this even 2 years ago, I would have said no. There have been studies that I think provided fairly good circumstantial data that transmission from patient to patient didn't occur. However, in the past couple of years, there have been 2 studies which have changed our thinking about that. The first was an outbreak report out of the University of Washington's Transplant Center, where the index case, who had had many years of positive smears and cultures for Mycobacterium macilliense, had a clinical deterioration in his status that led to the need for transplant. And when that patient was transferred into the transplant center at the University of Washington, within a short period of time in a transplant center that had had no recovery of Mycobacterium abscessus, there were 4 other patients that were positive for this organism, and some of them with disease significant enough that it was thought to lead to their subsequent death. When these organisms were analyzed by pulse field gel electrophoresis, they appeared to be identical, and there was fairly strong evidence that an outbreak had occurred. When measures were put in place to cohort patients within that system, and a detailed epidemiologic analysis was done to look for possible areas of transmission, once those corrective measures were put into place, there were no further new cases that were presented. More recently, published in The Lancet, was a study looking at whole genomic sequencing of all of the Mycobacterium abscessus group isolates from Papworth Hospital in Cambridge. And through the whole genomic sequencing, there were clusters identified of isolates that appeared very similar, and in many cases the similarity between patients was almost identical or greater than that obtained within patients serially over time that again points fairly strongly toward the possibility of patient-to-patient transmission. This was coupled again with fairly detailed sort of shoe leather epidemiology to look at tracking or transmission patterns that provides pretty strong evidence that transmission has occurred. So I think that is requiring some rethinking of the infection control processes, and I think that the guidelines in their final form will probably have recommendations that aren't yet complete about cohorting patients, particularly with Mycobacterium abscessus.
Well, thank you for taking the time to talk to me today. This is a very challenging problem, and I think your guidelines are going to be a great help to clinicians in trying to figure out how to diagnose and also treat and perhaps cohort individuals with nontuberculous mycobacterium.
Well, thank you, Peter, for the invitation. It's been my pleasure.
And thank you for joining me on this special edition of Cystic Fibrosis Review.